आपका आपका जो वीडियो है ना सर,
हाँ, तो
उसमें
ऊपर
ऊपर,
लाइव आ रहा है।
हाँ उस पे ट्रिपल डॉट है ऊपर, आपके स्क्वायर के ऊपर आपका जो पर्सनल वीडियो है ना, उसके इसको आप क्लिक करोगे तो तीन तीन डॉट दिखेंगे। म्यूट और तीन डॉट, ये ऑप्शन आएगा, म्यूट एंड थ्री डॉट्स। आपके स्क्रीन पे आप क्लिक कीजिए, आपका जो वीडियो दिख रहा है ना वहां पे क्लिक कीजिए।
हाँ, ओके, सो यूल गेट 3 डॉट्स।
थ्री डॉट्स के ऊपर क्लिक करेंगे ना तो रीनेम का ऑप्शन आएगा।
नहीं, खाली फोल्डर आता है।
आई विल ट्राई टू रीनेम यू सर।
अच्छा, यू रीनेम मी यार, कुछ कर सकते हैं। अदरवाइज इट्स
हाँ हो
ओके।
जाएगा।
आई डोंट वांट टू मेस इट अप, एटलीस्ट आई एम ऑन
नो
स्क्रीन
नो
यार।
हो जाएगा।
ये हर टाइम का लफड़ा है। आई एम सॉरी यार मनीष।
नो नो सर, आपका खाली आप स्पेलिंग देख लीजिएगा।
SRIDHR, या परफेक्ट।
परफेक्ट।
अरे ग्रेट ग्रेट, थैंक यू।
वेलकम सर। नाउ वी आर लाइव ऑन यूट्यूब।
या
गुड इवनिंग सर, रंगनाथ सर।
Good evening. Good evening. Very good.
जयंत सर, गुड इवनिंग।
Hello, Manish.
Good
Good
evening,
evening.
all.
गुड इवनिंग।
Good
I hope
evening.
I'm audible.
या
Yes,
परफेक्टली
yes.
ऑडिबल। थोड़ा आपका वीडियो सेंटर में आपका फेस है ना, इस तरह से कर दीजिए। हाँ दिस इज फाइन, दिस इज फाइन।
Okay.
मैं अश्वथ सर को फोन करता हूँ।
Oh, moderator has not joined yet. Yes.
Uh,
हाय जयंत।
Hi, Siddhar. Good evening. How are you?
बस फाइन।
Daruru sir. Good evening.
Good
Good
evening.
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 Welcome to.
Yeah.
Yes.
yeah.
Welcome.
Yes,
Good
sir.
evening.
Yes,
Good
sir.
evening,
Devajit ji. How are
Sharma
Good
you?
evening. Hi.
Good
Good evening.
evening. Yes. I think we met at Guwahati.
Yes. Yes. Yes.
Yeah.
Good evening, dear panelists. Ashwath here.
Hi,
हाय।
Ashwat.
Good
Good
evening.
evening.
Nice to see you.
Yes.
Meeting.
Good evening, sir.
सर हु इज
हाय
गोइंग टू शेयर?
I'm going to do that.
सो सर यू आर ज्वाइन फ्रॉम मोबाइल और
I've joined from mobile. If you can move the slides from your end, that'll be great, sir.
सर इट पॉसिबल प्लीज यू ज्वाइन थ्रू, क्योंकि माय कनेक्शन है
No,
सम
I'll do it.
इश्यूज।
No problem at all.
या
थ्रू द फोन।
Good evening. Good evening, everyone.
Good evening, Chetan bhai.
Hi, Chetan. Good evening.
Hi, Dr. Ashwath, Dr. Devjit, Dr. Jain Joshi,
Hi.
sir.
Good evening. Nice to see you. Yeah.
Same here. Dr. Murli, sir.
Evening. Yeah.
Yeah, good evening. Darul, sir, how are you?
Fine. Fine.
Yeah. Bala, sir, good evening. Bhaskar has joined.
नो ही इज नॉट ज्वाइन इट।
Let me give him a call because we are already 9 o'clock.
Yeah, wait.
I think he will take time. So I think before that we should start. It is 9 o'clock,
Yes,
right?
yes. Okay, yeah.
Okay. Okay, fine. Good evening, everyone. On
Good
behalf of
evening.
Pediatric Infectious Disease Academy, we welcome you all for yet another link of Super 11. And this is link 18 in Super 11. Nowadays, we are going more on a webinar modes because we have been having a ID clinical case series that is also running nicely, as well as international speaker program also. So it is so much of learning about ID. So thank you all for joining. And we know that skin and soft tissue infection is being a very, very common part of our integral part of our OPD practice. And that's why we have kept this particular topic for the today's discussion. And we acknowledge the presence of Dr. Bala sir, who is been like this particular program, who is a brainchild of Dr. Bala sir. Thank you, sir, for this wonderful initiative, which we continued under the leadership of Dr. Darur and then now Dr. Bhaskar Shenoy, sir. And yes, so now we have a wonderful moderator first, I must say, because Dr. Ashwath Durai Swami is, you know, that he was a backbone of our PIDA infectious disease quiz. And he was there all throughout our exercise of that national quiz on pediatric infectious disease. Thank you, Dr. Ashwath, for joining.
My
And
pleasure.
we have a wonderful panel. We know that because this skin and soft tissue infection is a best, food for thought for a generalist. And who better than Dr. Sridhar Ganpati, the best generalist, along with Dr. Jayan Joshi and Dr. Devjit. All three are the best journalists to pick. We are fortunate to have all three of them together. At the same time, we know that because when we talk about skin, and in certain situations, we are stuck up, and at that particular time, we need a pediatric dermatologist opinion. And for that matter, we have Dr. Murli. Welcome, Dr. Murli, on board. So first, I'll just request Dr. Bala sir to say a few words, and then we'll start with Dr. Ashwath.
Oh, thank you. Thank you, Chetan. Wonderful to have Dr. Ashwath perform today. And but I still remember in 2023, in the 22, in the NCPA at Vellore, he and Paniraman conducted a quiz. The hall was full. People are standing and listening. That's Ashwath for you. He's fantastic. He's a good general pediatrician, intensivist, and he practices only up to midnight every day. And his knowledge, his wisdom, and his photographic skills are brilliant. And I'm sure all of us would enjoy and learn. And of course, the faculty with Jayant and Sridhar. Sridhar is fantastic when it comes to anything in pediatrics, particularly related to skin and infection. And we have a distinguished microbiologist also. We have Dr. Devjit, who takes part frequently in our PIDA discussions. And I'm sure, like all of you, let me also listen to the discussions and learn more about SSTI. Thank you very much.
Thank you.
Thank you.
Thank you. And just a word of, welcome from Dr. Darur sir.
This has become the compulsory waiting for this program every month, right, Thursday. So it has become so much, we are addicted that we are eagerly waiting for this event. So let us start it rather than we talk about it.
Thank you so much. That's real chairperson. Thank you so much. And over to you, Dr. Ashwath. You can introduce your panelists according to your choice, and then you continue the program. Thank you so much.
Thank you. Thank you, Chetan Bhai. Thank you, SBSF, for being a constant source of inspiration to all of us at PIDA and even otherwise on how we should be professionally ethical and also be updated. So you are setting new benchmarks for juniors like us to emulate. So I once again thank PIDA for giving this opportunity for me to present a case series on common and not so very common conditions. I'm sure with our panelists and with our esteemed specialist dermatologist, Dr. Narasimhan, we'll be able to have an hour of very, very meaningful interaction. So as the case presented, when I share my slides, I'll be able to introduce my panelists better. But because it's a Super 11, we have also arrayed Super 11 cases for you people so that we can discuss and enjoy our learning on the way. Without any more time wasting, let me start with the PowerPoint presentation. I'm sharing slides now.
You are sharing now, Ashwath?
Yes, I am.
Yeah, okay.
Mhm. Are you able to see my slides?
Yes,
Yes.
we
Yeah.
can. Yeah.
Yeah, yeah.
Right. So once again,
This is
so
in
for the
mobile
first
mode, na?
panelist, yes, Ji. So for the first panelist, we have Dr. Jayan Joshi from Pune, who's even though interested in pulmonology by the CV that his sir has presented, he seems to be very well versed and very interested in infectious disease and has been a very active participant in all PIDA activities. Welcome you, sir.
Thank you.
We next have from the east, Dr. Devjit Sharma from Satribari Children Christian Hospital at Assam. He has also been very active with the PIDA chapter of Assam and has also been a CAP member and has been a regular columnist and writer on subjects of pediatric child health. And then we have our own rock star, Dr. Sridhar Ganpati from Mumbai. And I don't think sir needs any more introduction after the encomiums heaped on him by Dr. SBS. You can also see that he is preparing to write a book and release on trichoscopy. That shows how his interest in the skin and hair is not just skin deep, it goes much deeper than that. And to top it all, we have Dr. Murli Narasimhan from SRM Medical College. He is a professor of dermatology. So welcome you on board, sir. So we'll go on with the first case scenario. Myself, I don't think I need to introduce myself. I'm Dr. Ashwath. I'm a pediatrician. I have a special interest in infectious disease and I'm very curious to learn from stalwarts and from everyone possible. So I've been practicing and teaching postgraduate for the past 17 years at Coimbatore. So let's go on with the first case scenario. This is an otherwise well infant, 2 months old, who's come with the complaints
Dr.
of...
Ashwath, sorry to
Yes.
interrupt, but when we see on a laptop, it is seen
very small. Yeah.
it is seen very small.
Okay, we'll show.
We
I'll
can't
make it
read
full
it
screen.
actually. Yeah. I can't read it.
Yeah, I think we have to do it from laptop, then only it will be full screen visible probably. Or some panelists can do if possible if they have in their laptop.
I have, let's see, but I don't have the slide.
Okay,
Now
okay,
it looks
okay.
better.
Now it's
Now it's
fine.
fine.
Fine. You should,
Now
yeah.
it's
Perfect.
I think you made it horizontal, whatever.
Yes,
Yeah,
right.
Thank you.
So this
Now, perfect.
Everybody
Please.
is fine? Right.
Yeah,
Yeah,
yeah.
great,
So
great, great.
right.
Yes.
This is a first case scenario of a 2-month-old baby who's been brought to a pediatrician with this clinical picture after nearly a week of local application of mupirocin. Let's set the ball rolling with Dr. Jain sir.
Yes.
What are your thoughts, sir, on seeing this?
See, first and foremost thing, it appears to be something which is called as transient pustular melanosis. And it's relatively a benign condition. The fact that this child was already given a local mupirocin therapy for 1 week and there seems to be no sting. So this is something which is called as miliaria. It is not an infectious condition. It is a type of seborrheic dermatitis. And what one requires to do is just to keep a clean day, use a cleansing lotion to keep it clean. Most of the times it will disappear by itself. Now suppose if it appears and if it is it turns into a pustule, which are of bigger size, which is also a very common condition which is seen, which is like a staphylococcus scalded skin syndrome could be one differential here. And probably in that situation, if there is a recurrence, because most of the staphylococcal lesions would respond very well to mupirocin topical therapy. However, if you see more of recurrence there, you may require to use an oral antibiotic. But in this condition, probably an antibiotic is not required because it doesn't appear to be an infective condition. You can just reassure the parents.
Dr. Narasimhan,
Yeah.
so when we talk about pyoderma as generalists, we understand that there is a pyogenic infection of the skin. And when you have a pustular lesion with a reddened skin on the base, how can one be very sure that this is a non-infectious condition, considering the humidity of our country and consider the fact that the lesions are mostly in the intertriginous area? Can we be absolutely sure that it is not infectious? Can you please illuminate, sir?
See, whenever we have such pustules in the intertriginous area, we have to think of occlusion, because of which you can get sterile pustules. You can get it in candidal intertrigo, which is quite common in infants and it's very young children, because the neck area especially, they're not able to hold their head up. So that the skin in the neck and in the groin, these areas which are occluded and macerated, they can cause miliaria pustulosa also. And candidiasis is also common. So if you are applying topical mupirocin not responding, could be candidiasis. But so many pustules, when they are there, it is better to, as a bedside, if in a medical college or in a tertiary care center, we would like to just take a swab, do a gram smear, gram stain, Zang smear, as well as potassium hydroxide mount. We'll be able to see if it's a candida, if it's just a sterile pustule, or if you see gram-positive cocci, it could be staphylococcus. So bedside test is quite important in such conditions. And as Jain sir said, transient neonatal pustular melanosis is a very important differential diagnosis. If these kind of sterile pustules occur throughout the body, then we can even think of what is a condition called as acute generalized exanthematous pustulosis, which can occur as a part of drug reaction, or it can be even pustular psoriasis, which can begin in this way in infants. So,
sir is basically extended the differential diagnosis to both include benign as well as not so benign. And he's also made a point that it could be bacterial infection. We also need to be aware of the probability of a fungal infection. Is that correct, sir?
yes.
Dr. Ashwath, can I just come in?
Yes, sir.
Yeah, Dr. Murli, can I just ask you a query?
Yes.
In case if you are suspecting a candidiasis here, would you be expecting more of an erythema around the lesions?
Yeah, it is difficult to make out, but definitely there is erythema around the
base is it.
Base is erythematous, and you can see the clear pustule. No, in the sense, there won't be so many pustules in candidiasis.
Exactly.
So I was just referring to it as a differential. It is more of a shiny erythema. There will be satellite lesions and some pustules. So
Can I add something? Ashwath?
Sure, sir.
Yeah.
Ashwath, can I add something?
Yes, sir. You're welcome, please.
So this looks classically as an intertrigo, which has where mupirocin has failed. So it totally goes for a candidial one with that erythematous base that you see. Because when you take the other differential, like a transient pustular melanosis, which comes right from birth, it's not a very late presentation. It's right from birth, and they usually don't have an erythematous base, the transient pustular melanosis. Erythema toxicum, it belongs to that same category. which usually comes around about the second day, beyond the first 24 hours, and the palms and soles are totally spared. That's how you pick it up. And the transient pustular melanosis, as they heal, they leave behind a post-inflammatory hyperpigmentation. This sort of maceration, the red color, and the pustules would definitely, I would put my bet on Candida. Malaria is another one, Malaria pustulosa.
Malaria.
Definitely, yes. I would also want to take a small, like Dr. Dorasamy was saying, I would like to take a small swab from this just to see whether it is neutrophilic, eosinophilic, and a gram stain, which would really not contribute to a great excess because mupirocin has failed. So I'm not thinking of anything wherein it looks very much like in that particular area in a 2-month-old child where you can't extend, you still don't have your head holding set up there. It looks very much candidial intertrigo. And the
Dr.
second would be a
Narasimhan?
Malaria pustulosa.
Yes.
Okay. Dr. Narasimhan, I wanted some clarification on why we have so many terminologies for the
Yes.
same pyoderma.
So
Can you please elaborate?
Pyoderma can be classified as follicular and non-follicular. So non-follicular ones are the superficial pyodermas, bullous impetigo and impetigo, and ecthyma, which is the deeper form. Cellulitis and erysipelas also come under this category. Follicular involvement, there are three types. One is a simple folliculitis, where only the hair bulb is involved. Furunculosis, where the hair bulb and the adnexal bulbar area is also involved. And carbuncle is one where you have multiple furuncles occurring in adjacent. The treatment is very different. If it's a furuncle and there is a big and an abscess is there, you need to drain out the pus. If it's a carbuncle, you need surgical intervention. If it's just a folliculitis, a topical antibiotic would suffice. So
perfect, sir. So there is a lot of pharmacological pressure in the sense, now that most of us have been on the mupirocin bandwagon, we've been hearing a lot about a molecule called ozenoxacin, sir, which is also being used quite regularly by our colleagues. Would you care to comment about that as an alternative to mupirocin?
So generally, the spectrum of ozenoxacin and mupirocin are similar, and the biggest advantage, mupirocin resistance per se is quite rare. We earlier had a molecule called retapamulin, which went out of the market. It was supposed to help in MRSA infections, but it is no longer available. And ozenoxacin is a good alternative. We can try ozenoxacin. But now when you see so many pustules and like whether mupirocin was used as an ointment or a cream, that also makes a difference. Mupirocin ointments can be messy, sticky. It can occlude the follicles in that area. Already it's in a flexural area. So you should avoid ointment formulations because they can cause occlusion folliculitis also. So cream formulation or a gel formulation works better in the flexural areas.
Dr. Murli,
Thanks
can
for
I
the
just
words,
ask you
sir.
something?
Yes.
What about sodium fusidate? I mean, like, is it useful?
Sodium
Fusidic acid?
fusidate also is quite helpful, sir. Both have a good action against methicillin resistant staph as well as methicillin sensitive staph and streptococcus. So it does help.
Thank you.
Dr. Sharma, when would you consider giving systemic antibiotics to a child with pyoderma? What would be your considerations to give systemic therapy? Dr. Sharma?
Yeah.
Dr. Sharma, you are muted.
Here you see, we can see this whether Candida interagio or this pyoderma, this is limited to the area and child is not look toxic. In this case, obviously, I will not consider systemic antibiotic. Systemic antibiotic will think of when it is widespread, active almost all over the body, very large in number, it is drainable, infective the adjacent areas, red and forming pus to pus and bigger in size, and also there's infective around the area, and child is generally not well-being. It infected the infected some in areas where it can spread to other areas like dangerous area of the face. Child is lethargic and maybe total count and other is high, and child is febrile, then we can consider IV antibiotic, otherwise no.
Dr. Sridhar, before we close the scenario number 1, can I get your comments on when would you, as a generalist, be worried about a child who comes with recurrent pyoderma? What are the red flags? What would it point to, or when would you start worrying in a child?
So basically, I would be any unusual presentation or an unusual organism. I'm going to be thinking in terms of an immunodeficiency. So we do have these hyper IG babies with recurrent pyodermas, and you don't want to miss out on them. That's number one. Number two, I just wanted to add on to what was spoken before about the 3 preparations in the market that we had, if it is okay, Ashwat.
Yes.
Yeah, so one was sodium fusidate, the other was mupirocin, and the third was ozenoxacin. Now, what is very essential to understand is 1, the spectrum, 2, the depth that it penetrates, and 3, the effect that it has on the local microbiota. This is something which is of prime importance when you are using a local antibiotic. Now, the first talk was on retapamulin, which was a great drug. The spectrum was much more than ozenoxacin and mupirocin, but the skin reactivity was to such an extent that they withdrew it from the market, or it's not freely available. Mupirocin, we still don't see, though we have a lot of literature which talks about MRSA, which is not responding to mupirocin. Ozenoxacin, there was a lot of hype, but what we are finding is ozenoxacin became more famous because the cream form was available, whereas mupirocin, only the ointment form was available for quite a long time. So we had to shift to ozenoxacin for the, we didn't want that occlusive problem which happens with ointments. And coming to sodium fusidate, a drug that penetrates deep. So whenever you want something to penetrate deep, sodium fusidate comes to the fore. But what you need to understand is sodium fusidate does affect the local flora to a significant extent, whereas ozenoxacin and mupirocin don't affect the local flora to the same extent. The second thing, the question that you asked me is anybody who tends to get recurrent pyoderma. So the common things that we think of is an immunodeficiency. And one thing that we should not miss out is a juvenile diabetic can have recurrent infections. So recurrent pyoderma, recurrent fungal infections are maybe the initial manifestation of just a juvenile, of a type 1 diabetes mellitus in the pediatric age group. You can have hyper IG coming with the same problem. You can have a lot of skin barrier defects, the ichthyosiform and atopic dermatitis, who are more prone to staph infections because their local immune system is in a total disarray.
Thank you. So with those clinical pearls, I think we can move on to case scenario number 2. We are still on the subject of skin and soft tissue swelling. Dr. Sharma, I'll start with you. This is a 10-year-old boy who's come to our attention after a history of snake bite 16 hours ago. We can see a lot of tenseness, we can see shininess, and we can see swelling over the dorsal of the feet and the calf, extending all the way up to the popliteal area. And I've given you some investigations there also. Would you care to comment, sir?
Yeah. If it is history is definitely there are some snake bite, whether poisonous, non-poisonous, we don't know 16 hours ago, but you can see the child is having swelling and black discolorations of the limb, and it is spreading almost all of the limb. And if you see the investigation you have given me, total count is 21,000. It is increasing. Platelet count is 92,000. It will decrease in hemoglobin 9.4. I don't know the baseline, but it is still low. But interesting is the CPK is 4,556. So definitely differential diagnosis should be, it is snake bite cellulitis, snake bite gangrene, but with such high CPK, 4,556, it is most likely snake bite myositis. So it will treat it as snake bite myositis. You have to monitor. You see, in the snake bite myositis, we have to worry about, apart from treatment with the all anti-snake venom, antibiotic, and all. Snake bite, you see, it can cause a gangrene and myositis. It is directly due to it. Venom has some enzymes like peptidase and seropeptidase, we can damage the muscles, damage the soft tissue, and also it affect the blood vessel directly, decrease the supply, and usually hemotoxin snacks cause all this. And this CPK is so high, it is definitely myositis. So to monitor the case, we have to periodically monitor serum CPK as well as the renal function. We have to hydrate the soil apart from the electrolyte, serum creatinine, and serum myoglobin, potassium, and serum CPK. Along with our ongoing treatment with antivenom, IV fluid, lots of fluid to protect the kidney, and antibiotic with possibly due to the secondary infections.
Thanks for your insights, sir. Dr. Joshi, would you agree with Dr. Sharma, or would you consider some other differentials? We are sure that the dental hygiene of the snakes is no better than ours. So, considering such a short incubation period of 16 hours, would you consider this to be only a venom-induced sterile cellulitis, or is there a possibility of an infection, or should we pass this total count off as only a stress response? What's your take on this scenario? Dr. Joshi? Dr. Jain?
Hello, am I audible?
Yes, sir.
Yeah. So this seems to be a hyperacute process wherein we really don't know the type of snake, but must be a poisonous snake. And there is an acute amount of rhabdomyolysis, which is contributing to this particular high rise of CPK. I think looking at the overall picture, there is an element of cellulitis here. So I think we need to give an antibiotic cover.
Of course, antibiotic is must, yeah.
Yeah. So we have to give an antibiotic cover to this, and of course observe, because there is a lot of destruction. As Dr. Sharma sir said, you have to keep on serially monitoring the CPK levels and myoglobin. And most important is that the way it has rapidly worsened, you must monitor the kidney function. So I think what we need to do is basically to monitor for the local infection. Suppose there is a good response to empirical antibiotic therapy, we have to give a broad spectrum cover here and observe the child over a period of time. Of course, it goes without saying that you must give anti-snake venom treatment as is there.
So my question to you, sir, is
Yeah.
at this point of time, with a hyperacute presentation, within 16 hours of a snake bite, are we happy to treat this as a sterile cellulitis of only the venom being responsible for the destruction of collagen in the subcutaneous tissues with all the peptidases and the lipases, or is it prudent to cover it with antibiotic? Are we over-treating, or
No.
are we protecting the child from a secondary infection?
No, we are fully justified in giving him with an empiric antibiotic cover, because with the rapidity with which the worsening of this condition has happened, and the parameters are history of a very high count with a high CPK count, we must give an antibiotic cover broad spectrum in order to see that the septic element is involved here. So there is a possibility that at the fan mark also, there could be some secondary infection through that. It could be anything.
Yeah, and what I say, when along with the venom, when the snakes bite and prick in the side, along with the venom, it injects some bacteria and some infective agent also. So 16 hours is good time to that infection goes to the blood or it infect the muscles. So we must cover it with antibiotic as well. It is good time, 16 hours, because it is directly injected in the some vein or something along with the venom.
Dr. Sridhar, would you agree with the co-panelists, or would you beg to differ or give a different interpretation of what's happening in this child.
No, I think I'm in the same boat, but let me tell you one thing. This looks like a vasculotoxic bite. I mean, it's a vasculotoxic snake. And what has happened is we need to look for distal pulses. We need to look for perfusion distally. We need to look for hypoesthesia. And if the pain is out of proportion to what you can see there, you are definitely worried whether it is a compartment syndrome, because you do know that these vasculotoxic venoms, especially like the viper bites, can have a very significant morbidity issue there. That's one. Second, a snake bite is not a sterile bite. And we all know that. Only thing is it varies from region to region. And even if you go through the Indian guidelines, that when you have something of this sort, especially when it's so extensive, it is more prudent to use a broad spectrum antibiotic at the beginning. So what you need to look here is there is a drop in hemoglobin, there is a drop in the platelet count, and the CPK is high. So there is myonecrosis, tissue necrosis, and probably there is a big vascular element. And we need to work in faster, in the sense I would even go ahead and do an ultrasound. I would feel whether I'm getting any crepitus and things like that. So I would do a Doppler and ultrasound, though it may not definitely tell me about a compartment syndrome, but at least it will give me a clue whether I may need a better setup, whether I need to shift the patient in order to save that limb.
So that's perfect, sir. So what we usually instruct our PGs is to keep marking the upper mark of the cellulitis at the end of each duty so that the next person knows whether the disease is progressing or not. And they are constantly expressed to keep falling at the feet of the patient in more ways than one to keep sure that the distal pulses are well felt and there is no paresthesia or hyperesthesia and there is no discoloration in the soles. So those are very, very important points that we need to consider, especially in a myonecrotic hemotoxic point. The other important point that I would like you to enlighten us on, what would be your empirical choice of antibiotics? All three of you have said that we need to give broad spectrum antibiotics. Dr. Sridhar has also made the pertinent observation that the venom content of microbiology of the venom may vary from place to place. So is there a reasonably good empirical treatment to start with? And many of these viper bite patients also are at very high risk for acute kidney injury, more from the myoglobin that is filtering also, and because of the direct vasculotoxic effect as well as the shock effect. So are we happy to use nephrotoxic drugs like vancomycin, aminoglycoside? Is cloxacillin, clindamycin good enough? Or do we need to give gram-negative coverage with piperacillin, tazobactam? What's your take on that? Can I have a quick word from each of the three panelists on what their antibiotic choices would be?
Yeah, here we like to cover all this gram-positive, gram-negative, and also anaerobe, because we don't know what what organism he's going to get. So we'll cover some broad-spectrum cephalosporin along with some gram-negative coverage. For both gram-positive and gram-negative coverage, gram-positive, and also I will add some antibiotic like metronidazole to microbials like metronidazole to cover anaerobes. And regarding anti-rhinotoxic drug like amikacin and vancomycin, amikacin, of course, I will not use now here, but vancomycin, if I need it, I have other soils also, the linezolide, and so I will definitely monitor kidney function anyway. If it is kidney toxic is there, if myoglobin is increasing, I will overhydrate the fluid, and if kidney function is okay, output is fine, then if needed, I can use it.
Okay, Dr. Jayant?
I think
Your
I would
choice
go
of
for the,
antibiotics.
I would agree with Dr. Devashish. I think the best combination would be to take a broad spectrum cephalosporin like ceftriaxone, and you must cover an anaerobic, so you add a metronidazole to it. And since the kidney function could be a doubt here, you can't use aminoglycosides. So the best option is to go for something like Piptas, and that would give a adequately good cover. Alternative to that could be you can even use a BL-BLI combination like Comoxiclav. But knowing fully well, as Dr. Sridhar mentioned, when you do this kind of thing, you always look at probably isolating the bug somewhere. So maybe before doing all that, if possible, you could do a culture and then go ahead with this. But at this point of time, the broad spectrum cover should include all the possible things, because through the fang, we really don't know these viper bites. They need not be sterile. So what bacteria have gone inside? It could be a polymicrobial situation, and we have to cover all these bacteria in mind.
Dr. Sridhar, your choice of broad spectrum antibiotics?
Yeah. So first, I just forgot that I should have added one more thing about the regional lymphadenitis. So just like you were saying, you mark the upper level. We also keep a watch on the tenderness of the regional lymph nodes. That's another marker if it is spreading.
But would it come so early, Sridhar?
Yeah, it does come pretty early in the Viperidae type of bites. Not so much in the cobra variety, the cobra and the crate variety, but it's known when you go through those snake bite guidelines. And the guidelines, like what you all mentioned, yes, but I think to begin with, the co-amoxiclav is a good drug, which has a broad spectrum and covers most. And you keep a watch on what you're dealing with. So to begin with, a simple co-amoxiclav is good enough, and that is also given in the recommendations.
Dr. Narasimhan, we'll have the final word from the specialist. Are you in agreement with their assessment, sir?
Yes, definitely. We also need to measure the limb girth to see if it is expanding. That is along with the marking of the erythema and edema on the superior aspect. You also need to monitor the limb girth, because these kind of bites can go in for compartment syndrome, and then that will in turn worsen the condition. So myonecrosis, so you can see that there is coagulopathy, there is a component of infection, and there is a component of muscle destruction also. So I think I do agree with all three of them.
Perfect, sir. Thanks, sir. It is very nice to know that all the three pediatricians are passing with the help of a dermatologist. I'm very happy for my brother. So my PG, one of the smarter PGs thinks, why cannot this be necrotizing fasciitis? So is that a point to be considered? Considering that Streptococcus, Staphylococcus, especially Strep pyogenes, can produce a very similar picture, and we have already made the fact that there is a breach of the skin, there is devitalized tissue, there is an area of ischemia, and viper bites or what cobra bites are probably not sterile. How do we differentiate necrotizing fasciitis, which is another potentially devastating condition, from a simple cellulitis?
Yes, actually, this could evolve into a necrotizing fasciitis at a later stage. So it is a little early, 14-15 hours, but it is possible, like there could be rapid necrosis. We have seen the entire limb getting necrosed after viper bites. So in the place where I did my undergraduation in Sevagram, I have seen a lot of these farmers coming in like this, and post viper bite because viper bites are within 15 minutes you have swelling. Within 2 to 3 days there is massive swelling, and the swelling persists for up to 3 to 4 weeks also. These are some of the observations that I have had with snake bite patients.
So what is the clinical pointer which says this is or refutes the pointer or takes the diagnosis away from necrotizing fasciitis? What are the pointers to say that this is not necrotizing fasciitis yet?
It is not yet because I do not see any blisters over here, and I do not see frank necrotic eschar or something similar to a burnt out kind of skin. So it is very difficult to describe the dusky erythema and all, because many people in India are of a slightly darker color. So that dusky erythema may not be noticed, but when you have something like a purplish thing with severe tenderness, with small blisters, and then 1 or 2 necrosed areas in the skin, if you look carefully, then you can say that it is going in for necrotizing fasciitis.
Okay.
Dr.
So
Murali,
there are no...
would necrotizing fasciitis be more tender? There would be a lot of pain involved
Yes, there will be
compared to
severe
this.
pain, but yes, definitely pain component will be much more in necrotizing fasciitis.
Okay, sir. So there are no more comments. We will pass on to the
Yeah,
last with the
proceed.
pyoderma C.
Yeah.
So Ashwath,
Yes,
if I
sir.
could make a comment. So if you had presented this case without the snake bite, then we could have gone on to discuss necrotizing fasciitis.
Correct.
Especially if you had given me a marine person working in the seawater who's an alcoholic and he's got a liver disorder, and then he gets this sort of a limp. Yeah, I would straight away start thinking in terms of necrotizing fasciitis. Or if there is a drug addict or a diabetic patient who gets an injury and then he starts getting pain, which is out of proportion to what you see clinically, yeah, you start worrying about it. So I basically felt that would be another scenario if you had not mentioned the snake bite. Once you have the snake bite there, you know this is a result of the venom, and you know that there is a compartment syndrome which is getting in, and that you may have to get in at some time or the other. But you also know that there is going to be so much of a hemostatic problem that you first need to involve a hematologist to rectify everything before you cut open anything.
Because there may be two components, a venom-induced consumption coagulopathy versus a sepsis-induced DAVC. Agreed. Point taken that we need to stabilize the child hemodynamically even before involving the surgeon or putting a nick for lest we end up with a huge bleeding problem. Now, quickly moving on to case scenario number 3. Here, I would require Dr. Murli to help us distinguish and educate us on this finding as compared to the previous cellulitis. Dr.
So
Narasimhan, sir?
yeah. So you can see that the limb is very dark. This is what we call as a dusky erythema or a violaceous black discoloration. And then you see blisters. These are bullae. They are not just small vesicles. Bullae are large-sized blisters. And this is very typical of a rapidly spreading necrotic lesion of the skin as well as the subcutaneous tissue. So this is more likely to be a necrotizing fasciitis, and it is generally polymicrobial in
In pediatrics, what are the predisposing factors that we need to consider, sir? In the previous child, we had a snake bite, so the history was generally pointing towards cellulitis. Suppose this was a 6-year-old previously well child who's come with a short pyrexial illness and rapidly progressing discoloration of this nature. Would you say this is consistent with the picture of only necrotizing fasciitis, or would this also include the differential diagnosis of a purpura fulminans? And if so, what are the predisposing conditions that I would need to look out for, sir?
So it could be purpura fulminans, but you can see that there is normal skin and sharply demarcated areas. So this is more in favor of a necrotizing fasciitis rather than purpura fulminans. Maybe like if it's only on this limb, it could be just necrotizing fasciitis. If you have a generalized lesion like this, bilateral involvement of the other parts, then with similar kind of thing, it could be. Then sometimes toxic drug reactions could also trigger this kind of reaction. Although toxic epidermal necrolysis is more superficial, you could have certain drug reactions. The other possibilities are something like calciphylaxis, which can happen. Then gas gangrene is another thing if they've had a road traffic accident or a trauma. So that also needs to be considered.
Thank you, sir. Dr.
Can I just
Joshi?
come in, Dr. Ashwin?
Sure, sir.
Yeah. So I think if you are suspecting a child of this kind and you are hospitalized that child, there is a score which can help you distinguish whether it is a necrotizing fasciitis. It's called as LRI NEC score, and it takes into account 5 or 6 criteria. One is hemoglobin, second is total WBC count, you have serum sodium, glucose, creatinine, and CRP levels. And you make a score of all this, and then collectively you can make a prediction whether it is a necrotizing fasciitis. Second, as Dr. Murli sir said, that it is an exquisitely tender condition. So a disproportionate pain is something which will strongly keep of possibility of this in mind. And a child who is diabetic, or the child who has undergone a surgery, or if there is a trauma which has been maybe missed out or maybe ignored or not taken care of, that could be one of the triggers why you could get necrotizing fasciitis in this situation. And of course, immunosuppressed host like in malignancy, etc., you keep a watch of this. In such cases, of course, there would be a bad prognosis, and there is a chance that you could have a further worsening of condition.
One of the recent and very often overlooked part in any septicemic process is the amount of importance or the lack of importance given to source control. Very often we see a child with an empyema who recovers much faster after having a VATS or an ICD inserted. The pus comes out, the exotoxins, the endotoxins come out, and the child is seen to improve with the same set of antibiotics, same fluid, same ventilatory support, even 6 or 7 hours after a VATS procedure. So this is also probably one of the conditions where our surgical colleagues can do their bit and help in source control and letting out a bit of the endotoxins and the ectotoxins, and also making sure that the tissue tension is not going to compromise vital structures within. Is there any, in such a sick child, is there any place for local application like glycerin max self-dressing or local application of antimicrobials, Dr. Narasimhan, quickly?
No, I do not. You need skin cover, but I do not think topical antibiotics are going to be any help in this kind of a situation.
Dr. Sridhar, before we go on to the next case scenario, if a child was previously well, comes with such a rapidly progressing skin condition, are there any underlying factors apart from obvious ones like diabetes, in the absence of a history of a penetrating thorn trick or a previously ill child, diabetes, no systemic diseases? Is there a red flag? Should we work up these children for acquired
Yes.
protein C, protein S, antiphospholipid syndrome, stuff like that?
Correct. Antithrombin 3. So when you showed this photo, I felt it was Purpura fulminans. And this is like that NEET exam. When you look at the remaining questions and then you start wondering, oh, this is, you probably want the Purpura fulminans there. Now, this looks very much hemorrhagic necrosis. You would start thinking of protein C, protein S, and antithrombin 3 right at the top. If you had told me that this is a neonate, I would have, and you had that source control, so I would have thought of group B streptococcal infections and the C and S deficiency. If you had told me that idiopathic, I would have thought of zoster, herpes, group A streptococci. And in the infection scenario, the ones that inhibit protein C are usually staph, strepto, meningococci, you cannot forget, and the Clostridia. And I think Pramod, my friend, the ID consultant from Pune, was putting it down there. And he's absolutely right. We used to be very scared to use NSAIDs in chickenpox because of the hemorrhagic necrosis that we used to see in some. So I basically felt you were hinting at Purpura fulminans, and you wanted a little more on protein C, protein S, and antithrombin 3, and wherein we have what is known as a congenital problem in the neonate, and then the idiopathic one where you have the zoster and herpes, and the infection-induced alteration like a meningococci, and the remaining like a staph, strepto, H flu, and Clostridia.
So that is what the systemic therapy, if this child's clinical diagnosis was more in consistence with the Purpura fulminans, my question is whether we would still consider monitoring protein C, protein S, antithrombin 3, because this is well beyond the scope of our average pediatrician's lab support. So should we draw blood for protein C, protein S, antithrombin 3 upfront and treat the child like Purpura fulminans?
you need to do it, but there are ways how you collect the blood and you send it. So you need to follow all the norms, and you need to keep everything ready, because you have to rectify. Just giving an antibiotic is not the solution for any hemorrhagic necrosis. You have to keep this at the back of the mind. You need FFP, you need the other things. Now you get the protein C concentrate. They're pretty costly, but you need to understand what is happening at the tissue level.
Okay.
And as you
Points
rightly
taken.
said, extensive surgery may be required. As you said,
Correct.
source control is very important. So extensive surgery to rule out the toxin is very important.
Thank you. Thanks, dear panelists, for your inputs. Going on to one of the last pyodermas, again, a very vexatious problem which a pediatrician faces in office practice is a child who's come with a history of 3 days of progressive painful swelling over the eyelids like this. And the parents initially thought it was an ant bite or an insect bite and were happy to apply some cold compress. Now that the child's edema and pain is getting worse and he is not able to open the eyes, he's come to office with this complaint. Now, how do we differentiate clinically between something not so bad like a preseptal cellulitis from something which could be sight-threatening or even life-threatening considering the proximity of the emissary veins to the CNS, orbital cellulitis? How does a clinician make the differentiation between these two? And if at all you wanted to take help of a professional colleague, would you rather involve an ENT surgeon, considering that most of them could be extension from the adjacent sinuses, or would you favor an ophthalmological colleague? Dr. Sharma, your take on this. Dr.
You are
Sharma?
muted, sir. Dr. Sharma, you are muted.
It is, thank you. Yeah, it is very important to differentiate between pre-orbital cellulitis and orbital cellulitis, because pre-orbital cellulitis is simple and we can manage it on even simple antibiotic or antihistaminic itself, but orbital cellulitis is a serious condition. Usually, in both the conditions are unilateral. Pre-orbital cellulitis is mild swelling and it can usually child able to open the eyes, child not toxic, child there is no pain, child is can no pain, no difficulty in vision, child can open the eyes. And orbital cellulitis usually child is little more toxic, maybe febrile, child cannot open the eyes, there is difficulty in vision, pain is more. So it is different, important to differentiate. Once it is orbital cellulitis, we have to start antibiotic along with keeping in the mind. Usually most of the orbital cellulitis sources are paranasal sinuses, and we have to stir, and it is complications, maybe meningitis, cavernous sinus thrombosis, and it can spread, and it can be become septicemia. So we have to start with third generation cephalosporin along with the gram-positive cohort, vancomycin. So if needed, if we are suspecting Staph aureus, and regarding the consultations with ENT and ophthalmology, why we should consult, stick to only one? It is not that if we consult an ENT surgeon, we can consult an eye, and if we consult an eye, can consult an ENT. ENT we can consult because sources, of course, it is maybe sinuses, so he can see then and treatment. Or immediately, of course, he don't have to, most of the time, do not have to do any sinus surgery or so, but we can take his opinion regarding the source. And eye surgeon is important to see his vision and vision equity, and if any surgical drainage or other things will require, so we can consult both our ophthalmology colleague and eye colleague and ENT colleague.
Thanks.
Yeah.
Thanks for your input, sir.
Yeah.
Dr. Jayant, would you care to comment about the investigations? Would
Yeah, I
plain
think,
X-ray of the sinuses, ultrasound, CT, MRI,
no, I
what
think
would your go-to test be?
I think the most preferred investigation would be a contrast CT.
Perfect.
It will be visualizing paranasal sinuses, and that would help us to delineate the pathology. It would help us whether the source of infection is from the sinuses. That would also help our ENT colleagues in the due course of time, because after you stabilize the child after broad spectrum antibiotic cover, if it is a source is from paranasal sinuses, at some point of the time you may require to do a sinus surgery in order to remove the focus. So I think the best investigation here, most useful, will be a contrast enhanced CT scan, and that will give us the sinus pathology also. It will also give us a right on orbital pathology also. So you will exactly get an idea anatomically where you are located.
Dr. Sridhar, quickly, what would the microbiology of this? Because we think of it and talk of it as an extension of a sinusitis. Would the same H flu, Moraxella, strep pneumo be good enough, or should we be more cautious about Staphylococcus here?
Yeah, you need to be, because see, when you're talking about orbital cellulitis, you're talking about the orbital muscles and the fat there. And the fat doesn't have a good amount of vasculature. So necrosis can really set in. And you're worried about organisms seeping in from the sinuses and also from the oral cavity. Don't try to keep the oral cavity away from the picture. So you can have an extension from the oral cavity. You can have an extension from the ethmoid sinus, which is commonest because the lamina papyracea could be very thin and it could just leak in. So that's something which is very essential. But why is it that we jump into CT pretty fast is basically because it is pretty fast. Otherwise, we need to understand. A CT gives you a better delineation of the bony structures. And when you're looking at soft tissue masses, it's always better to get an MRI done. So CT is when you are very sure that you want to be looking at the bony masses.
To
Then
rule out the cavernous sinus thrombosis also we need MRI, I think. Yeah.
Yeah, so anything which is an
contrast is good.
extension, soft tissue, that is a better thing. So you, especially when you have a proptosis, when you have chemosis, when you have painful eye movements, and you know for sure that this is orbital cellulitis, you need to be working fast.
Okay. So the way we teach our postgraduates is to make a distinction between pre-cellulitis and orbital cellulitis to look for the P's. If the pain is disproportionate, if there's a lot of pyrexia, if there is proptosis, if there is paralysis of the movement, and pardon the bit of Tamil, parvapochana, which means if the vision is also compromised. So if these 5 P's are present, you're probably dealing with the orbital cellulitis, and please get the ophthalmic surgeon involved upfront. And as Dr. Sharma said, it need not be this or that. Both the ENT colleagues could be telling us whether the source is from the ENT. It could be even a dental issue, even a periapical
Yes.
abscess from the
Yes.
teeth could
Yes.
seep in and produce an orbit. So I'm sure even a dentist may need to be called in. So that's a very, very important point. So remember the piece: pain, paralysis of external ocular movements, proptosis, and painful loss of vision. These are probably simple markers that can help a clinician at the bedside to rapidly differentiate between. So going from pyodermas, Dr. Narasimhan, this is all yours. So we would just quickly run through this case scenario probably in 2 minutes. I have given some pictures, sir. These are all very common everyday occurrences in our practice, and we are not sure whether we get it right, especially with respect to warts and molluscum contagiosum. What is your take? What would you suggest we do, sir, apart from referring them to you?
Yeah, warts and molluscum are very common, especially in children, and the main problem comes when there are multiple lesions like these. So they are infectious conditions. You have a certain phenomenon called Kubner phenomenon. Here it is pseudo-Kubner phenomenon, where along the scratch lines you kind of implant the virus particle wherever you scratch. So these are contagious, and they are a source of big worry to the parents. And when there are so many lesions, it is, and for a child, like when a child is brought to us, we find it, if there are 1 or 2 lesions, we can cauterize, we can needle it out or curettage the lesion for molluscum. And for warts, we can cauterize or use chemocautery. But when multiple lesions are there, the problem is, of course, vexing, and we can remove them stage-wise. Topical salicylic acid containing preparations are good for warts, but molluscum, many times we see that it kind of subsides over a period of time, but still there is a lot of pressure from the teachers and parents of the child and the friends, parents who even happen to see this kind of a lesion. They complain to the teachers. So molluscum and warts you need to treat. So second, there are two hypopigmented patches. So one looks very whitish. On top, you have a child with a lesion which is hypopigmented with a central hyperpigmentation. So when you have this kind of a hypopigmented halo
Fungus.
with a central hyperpigmentation, our first diagnosis is a polymorphic light eruption, more than a pityriasis alba. So polymorphic light eruption is due to UV light sensitivity. It happens in two seasons. One is the spring and just at the end of autumn, where the UV rays, where the sun rays are very slanting and more amount of UV radiation reaches the earth. So you need to use sunscreens. Whereas pityriasis alba it will not have that hyperpigmented component in the center. It will be very finely scaly and that area will not tan. So when the child goes out, plays and comes back, you will find that that white patch is very obvious and striking because there is immediate pigment darkening and tanning which occurs on exposure to sunlight. So that helps us differentiate pityriasis alba from this polymorphic light eruption, because polymorphic light eruption will become very itchy as soon as you step out in the sun. And pityriasis versicolor or tinea versicolor is a misnomer. Pityriasis versicolor is a better term that we use. And it is also a vexing condition because it waxes and wanes. It's caused by Malassezia species, multiple Malassezia species. Initially, furfur was the only one. Now, plenty of other species are known: Globosa, Slufia, Pachydermatous, etc. But treatment with topical antifungals generally helps. But here in the picture that is shown, I'm not able to make out the type of scaling that's seen. But if you take your thumb and press and give a tangential pressure, the scales are removed en masse in pityriasis versicolor. Whereas other hypopigmented conditions without scaling, you should consider vitiligo or lichen sclerosis et atrophicus in the picture that is displayed.
Dandruff, sir? Is dandruff infective or is it just a scaly dermatosis?
Dandruff is not an infective condition. Generally, you do not get dandruff by using the comb of another person with dandruff. It has got a lot to do with our own sebaceous secretions on the scalp. It is a kind of hypersensitivity reaction to Pityrosporum orbiculaire, which is another form of Malassezia.
So can we say it's an immune phenomenon to the presence of fungus? So would fungicidal, because most of us are writing ketoconazole topical shampoo. So does it work, or is it enough to use just a regular shampoo without ketoconazole or ZBT?
Dandruff is called seborrheic dermatitis. So it is a type of eczema, which is a hypersensitivity reaction. So ketoconazole helps in removing the fungal load, the Malassezia.
It's a form of source control.
Yes. So in that way, it does help. So if it is very severe, we may have to use topical steroids containing combination with steroid and antifungal, which may help in the short run, but we are not supposed to use topical steroids for longer periods of time, because then again you will get scalp folliculitis and other complications.
So some dermatologists say that to remove the lots of Malassezia furfur, any shampoo will do, not necessarily ketoconazole shampoo. Is it true?
So what happens is there is colonization of the hair follicle, and many of the shampoos do not penetrate into the hair follicle. Whereas ketoconazole, if it is there is some reservoir effect which will help in clearing the follicular load of the pitrosporum. So that way it does help.
Thank you.
Yeah, Dr. Murli,
Thank
I
you.
just wanted to ask whether the first photograph is showing a depigmented lesion over the upper eyelid.
No,
So,
that's the effect of the light, I think. It's poor
yeah,
lighting in the
it
OPD.
is how the photograph has been taken. Probably, see, you can see even the lower eyelid, there is some hypopigmentation.
So I
But
started
the
picking in
one
terms
on
of,
the one on the side, no, it is, you can clearly make out that
The
hyperpigmentation.
center hyperpigmented spot.
This is very typical of a polymorphic light
Email.
erosion, also called
because I
as
started thinking in terms of a halo nevus with vitiligo there.
Yeah, correct.
Yeah.
Nevus depigmentosus.
No, nevus
No,
depigmentosus is a
nevus,
different.
halo nevus with
Halo
vitiligo.
nevus.
Yes, halo vitiligo is there. There will be a melanocytic nevus.
Yeah.
Yes.
Surrounding that, vitelliginous
New kind
patch
of
develops, and as the vitelliginous patch develops, the nevus will shrink in size.
So I
So
was
that
thinking in
is-
terms, and there is an association between the two. So I was thinking of that.
Yeah. But
And just Dr. Murli, just wanted to get it confirmed from you. When you are dealing with a pityriasis verticolor, I think it is also important to see other family members. You would often find similar kind of things in the family. So source control again there is very important.
so yes, mostly it is because of sweating,
Adding.
and it is because of humidity. People in the same place, same household can have. It could be also genetic predisposition where they have, although no genes have been identified, it is possible that they kind of secrete a similar kind of sebum which does not help in protecting against malassecial overgrowth.
And just an addition to that molluscum, because we always have a lot of problems with molluscum. So there is a new molecule which releases nitric oxide. It's a gel which has been released by FDA. Any idea of when it is going to be available here and how effective it could be in our setup?
Sir, for molluscum, actually, we are now using imiquimod, which blocks the toll-like receptors. So imiquimod, which is also approved for warts, does help. Topical cidofovir, which is not available here, and tea tree oil in a high concentration. There is formulation which is available. That also helps to a certain extent. But when there are multiple lesions like this, in the OPD, we educate the parents to apply potassium hydroxide on the lesions. So 10% KOH or 20% KOH can also be used as home therapies for these patients.
Does it leave behind any scar if you apply KOH?
It is a temporary. It is a temporary scar. It usually resolves.
Okay.
So after those fairly benign conditions, it's going to be back to an acutely unwell newborn. This is a case scenario which all of us will see in our practice, whether we practice neonatal medicine in a big way or not. Now, quickly, what are the thoughts? What are the infectious conditions when we see a erythroderma in a newborn? What are the life-threatening infectious conditions that one would upfront consider workup for and treated? Dr. Sridhar?
Yeah, so one would be congenital candidiasis. That is, you have a chorioamnionitis and the baby comes with the candida. It's not postnatal. Second would be a staphylococcal skin scalded syndrome. It could be a toxic shock syndrome. And we have seen a lot of contact dermatitis to a number of applications, even one which was to a boric acid solution that was used soon after bathing.
What about syphilis, sir? Would you
Yes.
consider syphilis in such a child?
Doesn't come with this. I mean, 90% erythroderma. We do find periostitis and tender limbs. We do find lesions on the palms and soles. We do find these snuffles right from the beginning. I mean, the leaky nose. But this sort of an erythema and at least I have not come across.
So
It
your
is there in the
differentials would be
differential.
primarily Candida and Staphylococcus. Am I right, sir?
Candida, Staphylococcus, even a toxic shock syndrome,
Yes.
and contact dermatitis to a
It
great
depends on
In your
the
experience during the COVID outbreak, did you see MIS-C in the newborn? What they call the MIS-N? Have you seen children presenting with this presentation? Newborns with multi-system
MIS-C,
inflammatory
huh?
syndrome, COVID-related,
MIS-C.
yeah. MIS-C.
I have not seen a
Yes, sir,
small
you've
child of this age. I had seen a child who was 3 years of age at similar type of price, but it looked like more like an erythema toxicum.
yes.
One more just to add to what Dr. Sridhar said. One more thing to add is herpes simplex probably could come like this, particularly with if you have some vesicles here.
Water.
Vesicular bullous, okay.
Yeah, so vesicular bullous type you can have. That will also come as an acute case in a neonate like this.
Okay. Dr. Narasimhan, would you care to comment on the non-infectious mimics of such a condition? We have talked about Staphylococcus, Streptococcus, Candida. What about conditions like SCID, Woman syndrome, Harlequin, Ichthyosiform erythrodermas?
Yes, you can have subcutaneous fat necrosis, which can present like this with erythema, especially in a neonate. So there are a lot of congenital ichthyosis. If you have small vesicles along with the generalized erythroderma, see, there is a lot of sparing of the folds that I can see over here. And the erythema is also blotchy and it's not completely uniform. If it was a uniform erythema with the scaling, we can consider Netherton syndrome or Omen syndrome or non-bullous or bullous ichthyosiform erythrodermas. And subcutaneous fat necrosis, especially when there is birth asphyxia, it is possible that it can present like this.
Okay, so another vexatious clinical conundrum we face is, what is the utility of swabbing the skin of this child and sending it for Gram-Stain on culture? Because in a newborn with wet diapers, with so much of contact dermatitis, moistness, humidity, Staphylococcus and Candidas can be considered as commensals also. So how can we ascribe a pathogenic role for finding Candida on staph of a skin with a red inflamed skin like this? Your comments.
It is, it depends. A lot of the flora depends on whether it was a vaginal delivery or a cesarean section. And the microbiome is totally different in case of both these conditions. And there is a lot of change which occurs in the microflora over the first 3 to 4 weeks of life because of contact with the environment, the type of diapers and the type of cleansing agents that we use, and also on the microbial flora that is there on the mother. So skin swabbing per se may not help much unless there are typical pustular lesions or just a skin swab may not. But if you find a lot of candidal yeast type of cells or pseudohyphae, candidal pseudohyphae, if they are there, then it is on a KOH mount, and you can consider it as having some kind of a virulent action.
Sir, one last question on this case scenario. Apart from cricket.
Ashwath, can I add something here?
Yes, please.
Yeah, so if it is a staphylococcal skin scalded syndrome, you need to look out for a focus, whether it's an omphalitis or an otitis media. Yeah, so it is usually there, and it is a toxin which is causing this. And this is one condition where you have paradoxical crying. The skin is so tender, you pick them up, they cry more. Whereas if you're thinking in terms of a candidial erythroderma, and you have an absolute friable placenta which has been delivered, you need to be looking at the placenta, not at the skin of the child. So I think that's the way to go about it.
Yeah,
And,
I want to just state, actually, see, if the child is how many days old and all other, how toxic and how childish behavior, it is all important, because it can be, while some benign condition like erythema toxicum and harlequin color changes, miliaria rubra and all. So first thing we have to see how the child is toxic, feeding, or lethargic, and at what days is it infected. Even it is some rare diseases of like ichthyosis and Sjogren syndrome and all, and if it is given vancomycin and stuff. So it all depends on the history. Just seeing the picture, it is difficult to differentiate it is Staphylococcus candidiasis or congenital candidiasis, Staphylococcus scaldus syndrome. First thing is the how sick the child is and how child is presenting.
Point taken, sir.
Candidial erythroderma can be absolutely self-limiting unless and until you have systemic candidiasis.
Yes.
Okay. So we'll quickly move on to something non-bacterial. This is also a fairly common problem. This is a child who has received nearly 3 or 4 courses of antibiotics and 2 or 3 ill-advised aspirations of this boggy tender swelling on the scalp before we were able to do a KOH preparation and demonstrate that it was a fungal infection, probably with an added element of a bacterial superinfection. Dr. Narasimhan, would you please enlighten us on how to go about fungal infections of the scalp, starting from simple tinea capitis to complicated tinea capitis? What are the absolute must-know knowledge for us?
So in general, tinea capitis is of two broad categories. One is the inflammatory variety where you have chirion and favus. The other is the non-inflammatory variety where you have a gray patch or a black dot type of tinea capitis. So although the treatment for all these conditions remains the same, there is not much of a difference in terms of the choice of antifungals that we use. But it is important to differentiate chirion from any other bacterial abscess, because one very important clinical point that can help distinguish between a bacterial folliculitis and a chirion is you just pluck 2 or 3 hair. If the hair comes out very easily, it is more likely to be a chirion rather than a bacterial folliculitis. So this is one simple clinical test that we can do from the lesion as well as from the periphery of the lesion. Just pluck 3 or 4 hair with your forceps. If it easily comes out, more likely in favor of a fungal infection. And it is better to get an opinion of a dermatologist or do a KOH mount yourself before referring to a surgeon. It need not be operated immediately, even if it is a bacterial abscess. Both chirion and bacterial pyoderma of the scalp can cause tender lymph node enlargements. So there is a lot of confusion in that. And it may also be secondarily infected. So sometimes pus pointing will be there, and then we do a gram stain from that, see a few cocci, and then think that it is a bacterial folliculitis. But KOH mount will tell you whether these involve the hair shaft internally also. So this is an endothrix type of invasion where the hair shaft is involved. So when you pluck the hair shaft, it breaks very easily. Favus, it is seen in our country. Most of the reports are from Jammu and Kashmir and in that area. We do not see it in southern part of India at all. And the organisms, mainly geophilic and zoophilic organisms like Trichophyton verrucosum, Microsporum ordini, Favus is specifically caused by Schonlein. And most all of these are not resistant to the regular antifungals, and many of them even respond well to griseofulvin also. Griseofulvin resistance has not been reported in tinea capitis.
What about the recent preference for terbinafine, sir? Because it seems to be equally efficacious and shorter therapies, smaller preparations, easier to swallow. Would you care to comment
Yes,
about that?
terbinafine 3 to 6 milligram per kg per day for 3 to 6 weeks is the thing. Generally, any hair involvement will take 8 to 12 weeks of antifungal therapy. And but tinea capitis responds much faster. Whereas if you have hair involvement in an adult, that is one of the main causes of recurrence. But in children, the tinea capitis, they tend to do very well with even shorter courses for 3 to 6 weeks. So you can get a mycological cure in 3 weeks' time
With terbinafine, sir?
with terbinafine.
Okay. And we've always been told about ectothrics, endothrix, and microsporum and trichophoton and the various species. And from the therapeutic point of view, from a pediatrician's perspective, in urine and blood, we always tend to culture. Here, does the organism matter, or will one drug work for the entire spectrum of
You
fungal
just
infection?
whether it's epidermophyton, trichophyton, or microsporum, all the antifungal drugs will work. So there is no, and it is also very difficult to detect specific resistance. By the time you do a culture and it comes after 2 to 3 weeks, the lesion would have progressed much more. So the moment you see whatever antifungal you are comfortable with, you can start.
Okay. Because when confronted by cases with such a presentation, the pediatrician was plucking his hair. For the first time, you have told us the importance of plucking the patient's hair, sir. Thank you for that clinical pearl. So one other condition that is commonly treated as fungal infection of the scalp with endless courses of topical antifungals or minoxidil, whatever is alopecia areata. Quickly, I know this is not an infectious disease, but because this is something that's so easily confused with the tinea capitis, can you quickly educate us on how to differentiate tinea capitis with the hair losing variety from the alopecia areata, sir?
So in alopecia areata, the skin is soft, it is shiny, and it is smooth. Whereas in tinea capitis, you may have erythema, that is redness. You will have some kind of scaling, and then you will have broken bits of hair. Now, these conditions, with the help of trichoscopy and dermoscopy, can to a great extent be differentiated well. So in an alopecia areata, if we do a trichoscopy, is nothing. It is just magnified imaging of the scalp, maybe 20x or 50x magnification we can use. And you will have small yellowish dots, which are the openings of the pore through which the hair comes out. So multiple yellow dots, if you see, it is more likely in case of this thing. Exclamation mark hair that you will get, because what happens in alopecia areata is the hair shaft suddenly becomes thin at one stage. And as the hair grows out, when this thin part comes to the surface of the scalp, it breaks very easily, leaving a exclamation mark hair. Whereas in case of tinea capitis, you will have multiple broken bits of hair. So you can have something called as pigtail hair or corkscrew hair that we can see. But simple clinical test, just by looking at it, it is just the shiny, smooth skin. Look, just take a magnifying glass, look. If there are a lot of open pores, if there are a lot of scales, you need to rule out tinea capitis. If there is absolutely zero scaling, then you think of alopecia areata. Also recurrence. So generally, you take a history. Most of the alopecia areata, there will be some kind of a past history. One patch might have been there, then multiple patches develops, and then it is having a waxing and waning course. sometimes when the hair regrows in alopecia areata, it may be white, then get converted to black hair. So this is another history which will help in differentiating between tinea capitis, which is recurrent, and this. For tinea capitis, most important history is history of tonsuring at temples. So that's most important history that we need to take visit to a place where they have tonsured the head.
Thank you. Thank you so much for the elucidation, sir.
Also, pitting of nails. Pitting of nails, you could see it in alopecia areata. And a trichoscope can be even used to assess the progress of an alopecia areata. That is, when you start seeing villous hair in the periphery, you know probably there is a response to treatment. I don't know, you can correct me, sir, if I'm wrong.
Yeah, usually when the hair regrows, it is vellus and less pigmented, and then it becomes terminal. That's why I said if the hair has regrown and there is a white hair that has regrown, which converts to black hair, in the history, it is more likely in favor of alopecia areata.
Quickly moving on to scenario 8, sir. Dr. Jain, sir, would you care to comment about these? These are all quasi-infective in the sense Stevens-Johnson's, Lyme, erythema multiforme, toxin-mediated diseases with sterile cultures, and erythema marginatum, which I personally have never experienced in my clinical practice. We know that these are hypersensitivity or immune responses to a preceding infections. In each of these conditions, there is a list of germs which have been associated with these. Now, how important is it for a clinician to try and eradicate the germ, or should we just treat this as immunological epiphenomena and not bother about the etiology? Would you care to comment, sir? Dr. Jain?
Yeah, so I think all these are immunological phenomena as we see in the form of erythema multiforme or Stevens Johnson, of course, can be a more severe course. It is, of course, it could be a drug-related process. Staphylococcus toxic shock syndrome again would have a source probably. Now, things which are life-threatening, probably where you require to do further investigation and go to the root cause to isolate the bug, because we need to cover the we need to cover the sepsis part by giving the broad antimicrobial cover. Now, as regards the erythema marginatum, even I have not seen any like this. Erythema multiforme can be a drug-induced phenomena. You withdraw the offending drug possible, and you will see over a period of time. At the end of the day, if it is very symptomatic, then only one needs to intervene. But conditions like Stevens-Johnson syndrome and Staphylococcus toxic shock syndrome definitely warrant an isolation of bacteria, because you are tackling, though it's a immunological phenomena, it can suddenly be rapidly worsening and can even be life-threatening at times.
Dr. Sridhar, what is it that is peculiar to herpes simplex and mycoplasma? I mean, why are they constantly on the differential diagnosis for any of these para-infectious phenomena? Are there any insights? And the two question is azithromycin given with these conditions acting like an anti-inflammatory drug, or is it actually working as an anti-mycoplasma drug? What are your thoughts?
The new concept about azithromycin is it's basically alteration of cytokines and alteration of microbiome. So since it is altering microbiomes as well as, because today when you talk about infectious disease, it's not an organism, it's a community out there. So if you create a community that is not suitable for something to survive, it's always better. And azithromycin is coming to the fore because it's even coming for pseudomonas. It's so surprising. It's even being used for pseudomonal infections and cystic fibrosis. So azithromycin has got multiple actions now. But the only problem with azithromycin, we need to know that they all have collateral effects. High doses, we are now seeing a lot of hearing defects. So it's alteration of cytokines, alteration of microbiota, changing the complete scenario.
So would a clinician be, in order to give a course of azithromycin in a child who presents with what we used to call the mycoplasma-associated rash mucositis syndrome or Stevens-Johnson syndrome, considering that we cannot prove mycoplasmal etiology especially in the setting of Stevens-Jones syndrome, child is so acutely unwell, would you consider giving parenteral azithromycin for a child in the hope that you are eradicating mycoplasma or you are affecting this cytokine storm, as so to say? Would you consider azithromycin as a therapeutic choice?
I wouldn't be able to comment on this.
Dr. Narasimhan, Dr. Sharma, what would your personal practice be?
Yeah,
Would you
Stevens-Johnson syndrome, of course, not. It is usually mostly due to adverse reaction due to drugs, and we have to treat Stevens-Johnson syndrome is mostly like burn cases, and that's how we take care burn, a fluid electrolyte balance, and along with, of course, antibiotic to cover the secondary infections possibly. And mycoplasma, obviously, we won't give any specific macrolide first to treat Stevens-Johnson, but REMS or MIRM, what we used to call it. We used to call it MIRM because it was only mycoplasma induced. We have to rash and mucositis, but now we call it RIME because we see it can be due to other infections apart from this mycoplasma. It is shown that treating with antimacrolide is not help, and usually most of the rheums are, if we treat them, if we give them supportive treatment, they are self-limiting. Once they will recover on its own. So obviously, I will not use macrolide for these cases.
Dr. Narasimhan, your final concluding remarks on the use of macrolides in immunobullous conditions. Dr. Narasimhan?
We tend to use macrolides because they are among the least of the drugs to cause any cutaneous adverse reactions. Although we have seen fixed drug eruptions to azithromycin or erythromycin, considering that we have treated a lot of these MIRM-like cases with azithromycin, it seems to be a good drug to give empirically also.
So moving quickly on to scenario number 9, Dr. Sridhar, as a seasoned veteran of general pediatrics with special interest in dermatology, what would your basic questions that a clinician need to ask, touch and feel, and how does he approach scaly depigment or a hyperpigmented, round scaly lesions? What would your approach be?
So the usual approach is whether it is scaly or not scaly. That's the first thing. And the second is whether the hypopigmented patch is associated with other organs being involved. So when you talk about a scaly lesion, you think of pityriasis versicolor, pityriasis alba, and the polymorphic light eruptions. So and seborrheic dermatitis. So if you find dandruff, seborrheic dermatitis. If the patient goes out in the sun and there is aggravation and you find pigmentation within the hypopigmented spot, very likely to be a polymorphic light eruption. If you have an atopy in the family, you may not even have an atopy in the family, but when you look at the lesion with a dermascope or a trichoscope or a magnifying glass, and you do find that there is a little bit of scaling and there is some amount of redness and there is atopy in the family, you think in terms of pityriasis alba. Alba usually merges with the surrounding skin. The pityriasis versicolor has a border, and you have the scratch sign that the dermatologist was trying to tell us. You use your nail and you get these perforaceous scales in a patient who has not applied anything on that pityriasis versicolor lesion. Polymorphic light eruption, I've already discussed. Black inside the white, you start thinking, and when you see a dandruff, it is seborrheic. The second category is when you don't find any scaling. So here it could be the commonest being post-inflammatory hypopigmentation. And the second category would be you need to use a Wood's lamp and you find a chalky white or there is an accentuation of the whiteness, you know it could be early vitiligo. So that's the way you go about a hypopigmented patch. And then the ones which are associated with organ involvement. Here you could have hypomelanosis of Ito or the ash leaf patch that comes very early in tuberous sclerosis.
Okay, how often do we see Hansen's in practice, Dr. Joshi? What's your experience? Tamil Nadu has a dubious
I have,
distinction of having the highest number of pediatric Hansens. So we see it at least once a year or twice a year.
I
What
have
is
not
your
seen, but
experience?
from the from the literature, what I have read and this thing, what is more important is it's a persistent lesion, hypopigmented, which probably will have a peripheral neuropathy. So I think a loss of sensation over the patch, a test which will distinguish the temperature test, would probably be the clue to find out. And of course, I personally have not seen a Hansen's in a child. Maybe the dermatologist can give us more information on that.
Dr. Sharma, what's your experience in Assam, in the east of India? Do you see pediatric Hansen? This is a picture
No,
of
no,
my patient.
I
You can
have
see the
not seen
biopsy mark
any.
also.
I have not seen any acute Hansen's neither in pediatric age group nor in adults. I've never.
Dr. Lakshminarayan, your final comments? When do we, as pediatricians, suspect that this might be Hansen's? Because frankly speaking, we do not check for temperature sensation. Most
Yes.
kids are quite scared and apprehensive as it is without us trying to poke and sense for hyposthesia, anesthesia, etc.
So Hansen's, we always suspect if it's a hypopigmented patch. So there are three cardinal signs:
Yes, sir.
hypopigmented anesthetic patch, thickening of peripheral nerves, and demonstration of acid fast bacilli. These are the three cardinal features. Now, on the face, if you have a hypopigmented lesion which is persistent and it is a small lesion, it could mimic pityriasis alba. There is one variety of Hansen's which is there in the Indian classification. It's called as indeterminate Hansen, where this kind of lesion it could be self-limiting also. Not all cases of Hansen's are progressive. This indeterminate Hansen could resolve on its own also. So indeterminate Hansen should be a differential diagnosis for hypopigmented patches on the face. And in this condition, you will not have, as you said, typical loss of sensation for two reasons. One, the lesion may not have significantly impacted the peripheral nerve. Secondly, face has such a large innervation from so many sources that you still have one nerve trunk affected, but another twig which overlaps the same area will give you the presence of a sensation. We generally check for sensations in most of the children by folding a piece of paper or a prescription. We do not use needles or pins to check for loss of sensation because it causes a lot of apprehension in both the parents as well as the child. So we fold a paper into four pieces, and then with one of the sharp ends we check for sensations. Secondly, Hansen's lesions are generally not very scaly. They have a kind of juicy appearance, a granulomatous appearance. I think the picture that is below, did it come out as a borderline?
Yes, sir. It was reported as
Yeah.
borderline cancers.
Yeah. So when you have a saucer-shaped lesion, it means it is a borderline leprosy. So a saucer-shaped lesion with kind of central depression, then peripherally raised margin. Granuloma annular is one condition where you can get a border which is raised.
What about tinea, sir?
Yes,
Tinea corporis, won't that also have?
usually you will have scaling, vesicles, and an itchy sensation in dermatophytosis. Hansen's patients generally do not complain of itching, but they may complain of pain and itching if they are going in for a reaction. So all borderline leprosy patients are unstable. So they can either shift or upgrade or downgrade. So when there is a reaction, when there is a type 1 reaction, you can have pain, tenderness, increase in redness, and although the margins remain the same, they become edematous. So dermatophytes, usually if they are steroid modified, then they can also present with inflammatory borders. You can get concentric ring within ring structures, and you need to do fungal scraping. So Hansen's generally, if you see a Hansen in a child, it means the source of infection could be there in the family. Family history is very important, because open lepromatous cases are very common in families of children who present with Hansen's.
So if I read you correctly, for the practicing pediatrician, it would be a combination of non-scaling, raised margins, saucer-shaped lesions, juicy granulomatous lesions with a peripheral nerve. If possible, look for hypoesthesia.
Yes.
If you're convinced, then we can go for a slit skin test and look for AFB. Am I reading you correct, sir?
Yes, sir.
Perfect. Thank you so much, sir.
What about sweating?
Yeah.
Yes.
Lack of sweating.
So lack of sweating is there, but
Yes.
lack of, if you have 1 or 2 patches, they may tell you can also expose the patient to sunlight for 4 or 5 minutes and ask them to come back, or do some walking and then come back to your room. And then you just feel for the presence of mild sweat on the surrounding skin and on the lesion. If the lesion is very dry, then yes, it could be. We don't do that histamine test and other things these days. We ask the patient to walk about and come, especially when there are multiple hypopigmented patches on the back and on the trunk. And so there are other variants. So we, in adults, we also think of other conditions like cutaneous T-cell lymphomas, which can typically present like this. And post-Kala-Azar dermal leishmaniasis can also present like this. So sweating, we generally ask them to walk around and then come back and then feel the skin.
The
Dr.
reason
Ashwin,
for
can I just
including
ask a
this.
query?
Yeah, sure.
Yeah. No, Dr. Murli, can you please enlighten us? If such a hypopigmented patch is seen on the face, could it be the effect of an inadvertent use of combination like steroid? Something like a hypopigmented lesion happening because of that, something like a tinea incognito, something of that type picture. So how does one distinguish in these two things? Of course, there would be a history of prolonged exposure to medication.
So you will, in tinea incognito, you will find usually a very red border. You ask them to stop using whatever cream they are using for 2 to 3 days. The whole lesion becomes very, very inflamed. In case of a dermatophyte which was inappropriately treated with this thing, just wait for 2 days, give some antihistamines, ask them not to apply any cream, and then ask them to come back, then do a scraping. So immediately after bathing or after application of a cream, if we do a scraping for potassium hydroxide mount, we may not get a positive result. So ask the patient to come back after 2 days after stopping the medication, and then do the scraping. We'll easily be able to pick up dermatophyte infections.
Thank you.
So the reason for putting up this scenario was to just highlight the fact upon pediatricians who are watching and who will watch it hopefully in the near future, that Hansen's, pertussis, diphtheria, Nipah, these are all not out of our sight. They're just out of our minds. So we need to be constantly keeping our antennae out for atypical presentations as something eminently treatable and contagious. That is the reason to put up this case scenario. Thanks. Coming to the last 2 case scenarios. So this is probably the pre-wrapping up session. This will be questions which you can all answer, my dear panelists. what are the skin and soft tissue infections that are warning signs of a more serious underlying disease? The picture on the left shows multiple molluscum contagiosum. This is a picture I sourced from the Indian Journal of Dermatology and Venereology. The right side is a child who was treated by an ENT surgeon for this necrotic black eschar-like lesion on the ear, which was destroying the entire ear cartilage. And the child was also failing to thrive and was having high swinging temperatures, was polyuric and losing weight. But unfortunately, the child was being treated only for the ear and skin infection without underlying disease being recognized. So would you please comment from your own experience where you found the skin to be a warning sign for something more sinister?
So this is a classic thing for HIV and immunocompromised states, sir.
Sure, sir.
This kind of molluscum contagiosum we usually see in people with underlying HIV infection, especially when the CD4 counts go below 200. And there is the other thing, it could be mucormycosis or I think it is more likely mucormycosis or some kind of
this child actually had diabetes mellitus, and this was Pseudomonas, which was grown from the blood as well as this was malignant otitis externa.
I think eczema gangrenosum was what I was trying to tell.
So this was Pseudomonas, sir.
Okay.
So there were two conditions which I thought which will highlight.
Hyper IG first one can be a
hyper IG too, sir. Yes, type 2, autosomal recessive.
hyper
Dr. Joshi and Dr. Sridhar, any snippets from your own experience, any gems, any pearls that the skin served as a window for something far more sinister underlying in your own case files?
Yeah.
I just
No, I think we have got a signal from the secretary that we are already overshot the time. So I
just
think,
one more case.
Okay, please.
Sorry, quick comment from both my panelists, please.
No, I think something a very important neurocutaneous marker would be, of course, a Caffioli spots. You should not miss it. You could have a connection with a neurological situation. You could have a refractory epilepsy. So that could be one particular thing which can be very important in neurofibromatosis has to be ruled out. But as regards infective thing, probably more than a skin lesion, I would be not missing upon sinuses, pre-oral sinuses or sinus, because these can be niduses through which the bacteria can gain an entry and can cause infections like meningitis. So I would be closely observing skin for any small sinuses, hair tufts, etc. And these are small clues which can be sometimes related to some kind of internal problem.
Herpes zoster. In my practice, herpes zoster of the face involving the tip of the nose, I missed it. I had to involve an ophthalmologist later on because the retina is one thing that gets affected because of the nasociliary nerve connection.
Oh.
So that is something I just wanted to talk on.
First one, it can be due to any immunodeficiency, but most of the skin infection like that we usually seen in hyper IgE syndrome. And second one, of course, Dr. he has saying it is usually associated with childhood diabetes and type 2 diabetes mellitus type 1. So we have to check sugar, though it can be due to any immunodeficiency as well.
Okay. Since we are running out of time and the secretary has raised the red flag, I probably will conclude here. Words do not suffice. And it is with profound gratitude that I thank Dr. Chetan, Dr. SBS sir for setting up the platform for this wonderful show. And I would be failing in my duty if I did not thank my panelists. Words cannot express our gratitude for those beautiful insights and those fantastic clinical pearls that have come up in this free-flowing discussion. As a matter of fact, none of these questions were prefixed. We thought that the panelists should have the spontaneity to answer just by looking at the picture so that there will be free flow of ideas and thoughts. Thanks once again. I would request Dr. SBS, Dr. Daruka and Dr. Chetan to give concluding remarks before we wind up the session. Thank you once again.
Moderation, Dr. Ashwat. Thanks for our
sir. Thank you, sir. Thank you, sir.
Thank you, Ashwat. Thank you.
And special thanks to Dr. Murli because we learned so many things from
yes.
a experienced
Yeah,
dermatologist.
and we got lost in those
Yes,
dermatological
so
things. We
and particularly
yeah.
Hanson's. Hanson's was really something we should be
Yes,
all
yes.
aware about.
It
Thank
is
you, Dr.
eye-open.
Murli.
We always keep something
Dr.
moving that
Ashwath,
must
can you
be.
just stop sharing?
Yeah.
Yes.
Thank you so much, Dr. Ashwath, Dr. Jay Joshi, Dr. Murli, Dr. Sridhar, and Dr. Dejit. It was a wonderful discussion. First, I would like to have a comments and from Dr. Bala sir, because he must have prepared some carry message. I'm very sure, because we have overshooted, so I'm not taking all the questions, but that has been very well appreciated all across the YouTube as well as this thing. Bala sir, please.
I'll finish very quickly. One,
Yes.
please do not use either fusidic acid or ozenoxacin for impetigo. The reason is impetigo is an easily treatable disease. The target attainment ratio for impetigo is very low. So don't worry, human beings' natural defenses will take care. Use mupirocin alone, do not use anything else. One. Two, regarding the treatment for the skin infections, one of the things we must all be on the lookout whenever there is severe infection in the skin, which is either not responding or recurring, we have to think of underlying atopy or immunodeficiency. But I still remember in India, one of the earlier reports of HIV was through insect biology and impetigo, severe impetigo. So we have to start thinking of immunodeficiency for any reason. Any child has got multiple infections, either bacterial or fungal or even viral. Third, please do not use azithromycin for Steven Johnson syndrome. I'm sorry, I disagree with all of you. Please do not use, it's useless. It's absolutely useless. In fact, I can give you a reference in Archives of Disease, an article of a case scenario of mycoplasma-induced mucositis. The message is don't treat. Treatment is not known to alter. So you can't, even if it is mycoplasma pneumonia-induced Steven Johnson, azithromycin or antibiotics will not alter the course. It's like, HSP. HSP, many people think it could be bacteria. It could be secondary to bacteria. It's an immune response. Treatment with antibiotics will not help. So I think we should not be giving antibiotics. On a similar note, doing skin swaps for anybody with erythema is a waste of money. It's like doing a skin swab for somebody with burns or scalds. No, you should do only a tissue biopsy and send it for culture. Skin swab will grow Staph aureus. It may grow streptococcus. It doesn't mean anything. Doing skin swab is absolutely useful. In fact, I'm happy that the dermatologist said you must do only a pus culture, not a skin swab or a tissue biopsy culture. Skin swab should not help our decisions on antibiotic use for skin and soft tissue infection. And finally, in skin and soft tissue infections, we have to adopt two orphan groups of drugs. One is cephalexin or cefadroxil, the other is cloxacillin. We have been misusing azithromycin for every place. We should stop using them and using only this. And finally, eye opener on Hansen's. Anything in the face which is white, we shouldn't be. We pediatricians either we give a antifungal, or we give a steroid, or we give both. But of course, the dermatologist will always say, don't use, but it is the dermatologist who use both. So pediatricians not use. No, I'm sorry. It's a fact of life. Like pediatrician, dermatologists also, they use only both. So the combination therapy for any skin lesion should be stopped. And last but not the least, we have some dangerous skin conditions, dangerous skin infections, and amongst which necrotizing fasciitis. In the case that was shown, that snake bite, I don't think it is infection at all if it occurs within 16 hours. You can't have necrotizing fasciitis after an injury within 16 hours. It is only a venom-induced one. And whatever antibiotic we should give should be only prophylactic antibiotic. The best prophylactic antibiotic for snake bite is amoxiclav or ampicillin sulbactam, not vancomycin and piperacillin for such cases. I think giving such heavy drugs for preventing is probably not rational. And last, brilliant, Ashwath. Hats off to you.
Thank you, sir.
Nice
Thank you so
choice
much,
of
sir.
cases. And all
Thank
the
you, sir.
four were simply superb. The dermatologist is outstanding. I learnt a lot from him. And of course,
Thank you,
Sridhar is a pediatric dermatologist by himself. The other two are very good generalists who threw very good points. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you so much, sir. Well said and well summarized the other good carry-on messages and clarifications. So it was a wonderful session all throughout, and I'll request our past chairperson, Dr. Darul sir, to thank and end the session. And before he says, I'll just thank all the panelists and moderator for wonderful session and all the dignitaries to be there on the dais. Okay, Dr. Darul sir.
Am I audible?
Yes.
Yes, sir.
Sir, what people are thinking is reverse. Syphilis has not left, it is reborn. Likewise, Hansen's is common. Adult and children are being diagnosed in our place. Plus, whooping cough has come. We have to be more careful because it is the thing that is being forgotten is re-emerging. So with this, syphilis in children and Hansen in children, tuberculosis in children is multiplying like anything. Keep a watch by doing this all skin clip and manto and other methods which you want to do. Thank you.
Thank you.
Thank you so much. It was a wonderful session. Thank you so much. Good night.
Thank you. Bye bye.
Thank you. Thank you.
Good
Thanks a
night.
lot.
Bye.
Thank
Good
you.
night.
Good night.
Thank you.
Thank you, one and all. Good night.
Thank you. Thank you. Good night. Good night.
Thank you.